The next speaker is Deepthi, Adjuvant Tramb in post-COVID ROCM.
RMC. I'm presenting chapter on Adjuvant Tramb in post-COVID ROCM. No financial interests. Introduction. Mucormycosis is an aggressive fungal disease with high risk of mortality. Causative organism is from Mucorrhizae family with Mucor, Rhizopus, and Absida commonly implicated. Fungal spores inhaled cause sinusitis, eventually spreads to adjacent structures like orbit and brain. Immunocompromised patients with poorly controlled diabetes carries highest risk. Recent times, we have seen sudden surge of mucormycosis cases, especially ROCM, who have tested positive for SARS-CoV-2. Mainstay of treatment involves reversal of patient's immunocompromised state, aggressive treatment with systemic antifungals, and surgical retreatment. Unique and potentially growth-sparing approach is retrobulbar antifungal injection (TRAM), usually recommended in preserved vision with focal involvement of orbit, unavailability of amphotericin B for intravenous use following sinus debridement where orbital wall has been breached. Methodology. This is a prospective intervention study done in 50 patients admitted in Mucor ward after radiological diagnosis at tertiary care hospital from June 1st to 31st August 2021. Inclusion criteria. Patients radiologically proven ROCM stage 3A and 3B at time of admission with history of SARS-CoV-2. Exclusion criteria. Patient with no history of SARS-CoV-2 with history of other immunosuppressive disorders with stage 1 and stage 2 disease with no orbital involvement. Patient with history of COVID-19 presenting with ROCM symptoms subjected to RT-PCR test. Negative patients were admitted. Detailed history, ENT, ocular, dental examination was done. DNA, radiological examination, nasal swab were taken. Complete ophthalmology evaluation was done. Bed investigations were done. All patients were monitored daily by a team of doctors. Procedure of TRAM. Patient was asked to lie in supine position. Baseline IOP noted. Under aseptic condition, 1 ml of diluted liposomal amphotericin B was taken and given retrobulbar injection. Any reactions was noted. TRAM injections were given consecutively for 3 days. Daily monitoring of IOP is done. Patients were continued systemic antifungals and subjected to sinus debridement. They were discharged after 2 weeks and were followed up weekly. Response to TRAM complications and progression were noted. Results. Age. The mean age of the patient was 50 plus or minus 10 years. Sex incidence. Incidence in males is more than females. The average duration between COVID positivity and ROCM is 23 days. Average visual acuity in affected eye is 618. Stage of the disease. Most of the patients presented in stage 3B of the disease. Outcomes. Spread of the disease halted in 42 patients, progressed in 8 patients, complications occurred in 7 patients. In patients with progressive orbital disease where FES was delayed, TRAM injections were given. Orbital spread was curtailed in those patients which allowed for flow preservation. This is an endoscopic picture of orbit in a patient with ROCM given TRAM showing curtailing of disease spread during FES. This is a picture of patient with complete ptosis, chemosis, and external ophthalmoplegia at time of admission. After TRAM and sinus debridement, chemosis regressed, ptosis and external ophthalmoplegia got improved. Complications occurred in 7 patients. Raised intraocular pressure. These are tablet Diamox 250 mg daily, 3 days. Vitritis and yellowish discoloration of conjunctiva seen in 1 patient each. Further progression of disease observed in 8 patients. 7 were managed successfully with IV amphotericin B and FES. 1 patient needed orbital exenteration. 1 patient succumbed to death due to mucor-related complications. This is a picture of orbital exenteration in patient after TRAM. Mucormycosis has been recognized as a rare fulminant life-threatening disease belonging to order Mucorales. Presents in many forms which include rhinoorbital cerebral, pulmonary, cutaneous, gastrointestinal or disseminated disease. The onset of COVID-19 pandemic, we have seen an alarming rise in the number of cases of ROCM with COVID-19 affected patients. The background of poorly controlled diabetes seen in patients with COVID-19 mucormycosis jeopardizes the host response. Furthermore, steroid therapy for COVID-19 management leads to impaired glycemic state and as well as waning immune response. Angioinvasion with infarction is the hallmark of mucormycosis. Resultant infection contributes to typical vision loss, premaxillary, periorbital soft tissue involvement, and necrosis of underlying bone. Liposomal amphotericin B is the antifungal of choice. In addition to systemic antifungal treatment, reversal of patient's immunocompromised state, surgical treatment serves a critical role. With progressive disease on maximum systemic medication, retrobulbar antifungal treatment acted as a non-surgical option to potentially halt orbital progression. Case report of retrobulbar antifungal injection treatment of orbital fungal infections have been reported. Sometimes FES surgery can be delayed due to logistics like high volume of patients, elevated D-dimers, and uncontrolled blood sugars. TRAM given in these patients showed response in the form of halting the progression of disease. Response with both systemic antifungals and TRAM would have played a role in the outcome of the patient. TRAM injection may cause a post-injection pro-inflammatory state called orbital compartment syndrome managed by the lateral canthoid. But in our study, we did not encounter orbital compartment syndrome. Close monitoring of patients' orbital examination, including intraocular pressure, was critical. In our study, some patients developed raised intraocular pressure after TRAM and were managed medically. Conclusion. Mucormycosis is a fulminant disease leading to fatality within 72 hours. Systemic antifungals, reversal of immunocompromised state, and surgical treatment serves a critical role in management. But in case of delay in phase in progressive orbital disease, retrobulbar amphotericin B treatment should be considered as an option prior to exenteration. Tramb, it is a viable option to consider in halting orbital progression and providing an opportunity to avoid exenteration and spare the eye. Though it carries its own risk, it can be a successful therapeutic alternative to conventional therapy and allows for orbit and globe preservation. Thank you.
Can you elaborate what is Tramb?
Good morning, sir. Transcutaneous retrobulbar amphotericin B.
Okay, liposomal. What was the difference between, was there any, did you differentiate patients whom you wanted to give Tramb and whom you wanted to observe without giving the retrobulbar? Was there any?
I took only patients from stage 3 and 3, sir, with minimum orbital involvement. But stage 2 diseases, stage 2 patients were observed, sir, not given any Tramb. But from stage 3A to 4B, some patients were selected for Tramb, sir. There are only vision is preserved. But all other patients above 4B and 4C, they went for examination, sir.
No, my question is very clear. So you wanted to give retrobulbar amphotericin B. You knew that there will be orbital compartment syndrome because of the inflammation because of retrobulbar amphotericin B. So did you observe any cases where the improvement was equally good where compared to the retrobulbar amphotericin B given? You have not given to some patients. So there was equal improvement just with systemic amphotericin B. That is my question. That is first thing. And second thing, whether any secondary complications post retrobulbar. After giving retrobulbar amphotericin B, was there any vein occlusions or compressive optic neuropathy or anything like that? Did you observe these two? Whether observation was done or not in this study?
We observed, sir, with Tramb there is a better outcome, sir, rather than without Tramb. And post Tramb we did not observe any occlusions, sir. Only 8 patients were progressed, sir, in my study. So almost 84%, 80% patients recovered with no complications, sir. Only 8 patients progressed, not visually, sir, but to brain structures, intracranial spread is there, sir.
In spite of it.
But they were managed medically with the other systemic antifungals, sir. They didn't went for any examination or that.
Post exenteration also you need to continue antifungals whenever there is any
Systemic antifungals should be given post exenteration.
how long?
For 4 weeks, ma'am.
4 weeks only.
And we can continue. We can shift to oral post-consult for 4 weeks, ma'am, for 1 more month.
Total 2 months.
Yes, sir. Pre-term and post-term. Before giving transfer, we measured baseline IOP, ma'am. And after post-term, every day before giving injections, we measure IOP, ma'am. In some patients, in 4 patients, we observed there is rise in intraocular pressure, ma'am. But it was managed with estrogen 250 mg BT for 3 days.
What's the instrument you used for measurement of the intraocular pressure?
Because patients are most of them are bedridden, ma'am, we went for shears from. We couldn't do applanation, ma'am.
Is it equivalent to applanation?
No, ma'am, applanation is more gold standard, ma'am, but patients are bedridden, ma'am, so we went for shears.
There is so much of infection and inflammation, no? So how will you use shears? It's very cumbersome to use in infectious patients, no?
Before using, we clean it, ma'am, with the spirit and all. We sterilize the instrument and with antibiotic drops, everything, we make sure that the infection is not.
What is the best instrument for measuring the bedridden patients?
Bedridden test. New advances are there, ma'am, tone up and all this, but
Perkins tonometer. Perkins. Perkins is equivalent to applanation tonometer, but you can use Perkins on bedridden patients.
okay.
And the recent instrument like eye care also I can use.